Hello and welcome to all, and thank you for joining us today. Today's May 17th, 2016, and this is Hangouts with HIVE. Our Hangout on air today is Sexual Health and HIV Prevention, a Transmasculine Perspective. My name is Yamini Oseguera-Bhatnagar, the Power Health Coordinator at HIVE, which is a hub for positive reproductive and sexual health, and I'm participating in this Hangout live from San Francisco. A couple of quick housekeeping items before we delve into the content of the hour. We will broadcast live for the next 60 minutes. During this time, as you listen to our panelists, please think about questions that you may have and type them into the Q&A box, which should be on the bottom right corner of your Hangout screen, and you'll need to sign into Google Plus to do this. You can also email your questions to hive.online2015@gmail.com. Also, please feel free to chat with us in this Hangout question and answer box. Share your thoughts or reflections. Give kudos to our panelists. We'd appreciate that. You can also join the conversation on Twitter by using the hashtag TransMSM, and also showing love to our very own California PrEP Provider Directory, hashtag pleaseprepme.org, or hashtag pleaseprepme. If you missed this live broadcast and are watching the video of the Hangout, you can click on the beginning or end of the video to be directed to a list of resources and a feedback form, etc. Today, I'm joined by esteemed colleagues from Oakland, Boston, and Seattle. Thank you for being with me today in this Hangout. And I would like to just go ahead and introduce you all to them. Let's start with Brandyn Gallagher. Brandyn is the Executive Director of Outshine Northwest and is a community servant whose passions include supporting healthy, consensual, and empowered sexual pleasure for trans folks. He is a leader of the PrEP Facts Facebook group, PrEP Facts Rethinking HIV Prevention and Sex, and the TransMSM Rethinking Sexuality and Health Facebook group as well. These are evidence-based community education groups, and he works with researchers and healthcare professionals nationwide to address the importance of trans-inclusive medical science, and is one of the visionaries for this Hangout today. Thank you, Brandyn.
Thank you.
Erica Woodland is a licensed clinical social worker, a consultant, and a healing practitioner who works in communities most impacted by the prison industrial complex and HIV. She is currently the field building director for the Brown Boy Project, as well as the clinical supervisor for the Crush Project, woot woot, a program focused on increasing sexual health services for queer men and trans people of color in Oakland. Oaktown in the house. Dana Pardee is an epidemiology projects manager at the Fenway Institute at Fenway Health in Boston. He currently manages the day-to-day implementation and operations of multiple transgender health studies, including the Transmasculine Sexual Health Collaborative, Project Life Skills, and Life Skills for Men, which we'll hear a little bit about in a minute. Dana has been working on behalf of the trans community for many years, both in Boston and in his home state of Nevada, where he helped conduct the first ever needs assessment of the transgender community in Nevada. Thank you for your work, and thank you for being with us today. And last but certainly not least, Adriane Ellis is a queer, trans, and genderqueer identified certified nurse midwife whose clinical practice is focused on providing sexual and reproductive health services across the lifespan for people of all gender identities. His advocacy work has included launching an online transgender health toolkit, which will be included in the list of resources later for you all who are interested in looking at it. Mentoring healthcare staff, providers, and students on LGBTQ health, conducting original research on transgender pregnancy, and championing midwifery care for transgender people within his professional organizations. This is a fierce group right here. Thank you all so much for taking the time to engage in this important conversation today. And I want to share a little bit about HIVE. HIVE was founded in 1989 and is the umbrella organization that encompasses clinical care, training, advocacy, and a virtual hub for disseminating best practices for comprehensive HIV-informed reproductive and sexual care. One of the ways we do that is via these Hangouts. Our mission is advancing reproductive and sexual wellness for individuals, families, and communities affected by HIV in San Francisco and beyond. Our vision is to see a world where people affected by HIV have safe pregnancies, reproductive autonomy, access to state-of-the-art health care, and, most importantly, enjoyable sex lives. So today we're going to initiate a very important conversation about sexual health and HIV prevention for transmasculine folks who have sex with cisgender men. We hope to highlight some of the nuances, to call attention to some of the important research that is already taken place, and then discuss what some of the gaps that still remain are. As some of you know, health research on trans folks and gender conforming people is limited. Transmasculine folks who have sex with cisgender men or trans MSM have, for the most part, not been included in HIV research. TMSM or trans MSM engage in sexual behaviors that place them at risk of acquiring STIs through HIV, yet no trans MSM specific interventions have been developed. So with that, I'd like to hand over the mic to my friend and colleague, Brandyn Gallagher, to tell us, to talk to us about transmasculinity, the spectrum, the experience. Talk to us, Brandyn.
It's a very wide spectrum. So I think one of the big questions that comes up for me in doing the work that I do is really like, how do transmasculine people have healthy sex lives while navigating sort of the alienation and the lack of resources that tend to surround our sexual health. Not necessarily our internal experiences of alienation, but the alienation that we face with our doctors, and how do we get them to not alienate us? And with our potential partners or people that we're trying to hook up with, how do we navigate those conversations about our sexual health in ways that are also affirming for us? Because in a society where like our humanity is up for a national debate right now, like legislatively, I think it's really important that we be able to have those conversations from a position of recognizing that we actually deserve the same quality of healthcare that straight white cisgender men receive, and recognizing that our providers are on our payroll, and that when we are going to them for resources, we need to be able to have those expectations that they're going to do their job for us just as well as they would do for anyone else. So I think those are a couple of the big complexities that make transmasculinity sort of a little bit more complicated in these contexts of figuring out our own ways of how do we have these conversations, and how do we build community around it, and how do we affirm ourselves in the process of having hot sex, because that's, well, for those of us who like to have hot sex, that's what we're there to do, right? And the conversations about the medical aspects of it are not usually very sexy. So part of that means getting trans MSM included in research. It means showing up to volunteer in the research. It means putting some pressure on our doctors and on researchers and on community health advocates and aid service organizations, other HIV provider organizations, and asking, where is your transmasculine visibility? Why don't I see myself reflected in what you're doing? Why aren't you training your providers to do better for us? And then having those same kinds of conversations in gay bars, and having those same conversations in the grinder conversations and the scruff conversations. Like, we're part of the MSM community for whatever that means. And just because the CDC didn't think that we were part of the MSM community at the moment that they coined the term, doesn't mean that our sexual behaviors aren't placing us into that category where that is clearly where we belong. And behaviorally, we can see the data bear out that I'm sure Dana will talk about more later, that we're engaging as a community in much higher risk sexual behaviors, largely because we're facing things like increased domestic violence, more coercion and abuse from cisgender men who don't know how to relate to us, or maybe don't care how to relate to us, and just sort of take this approach of like, well, you're trans, so who would want to hook up with you anyway? And then that wears down our sense of self-esteem. And I know that's not everybody's experience, but I feel like I've heard that as a lot of people's experience in the conversations that I've been having. So I'm just really excited to be having this conversation now about how do we do something about that, and what are some steps that as a community we can take to remind ourselves that we deserve good sexual health care, and we deserve good and happy and healthy and consensual sex lives. And our trans masculinity is not something that we should have those things in spite of, but that we should have those things sort of in combination with and as a supplement to having happy lives, because transness actually is kind of an awesome thing when you think about the awesome parts of it and not the legislative parts of it.
Awesome, Brandyn. Thank you. You bring it every time. Providers are on our payroll. We'll hear more about that in a little bit from Simon as well. You know, the MSM community and how inclusive is it, and how CDC definitions can sometimes mold our experiences as people as well. Thank you for talking about intimate partner violence, domestic violence, transphobia. These are extremely important pieces of how we experience ourselves in this society. Let us turn over to Erica Woodland, also a wonderful friend and colleague. Erica will talk to us about intersectionality and about how often systematic oppression can affect how we take care or don't take care of ourselves, and what that means for folks. Erica, take it away.
Thank you so much. It's actually really amazing to be a part of this conversation. A lot of what we're going to be talking about today, I talk about in my head all the time, or to a few other folks, I feel like, in the HIV field who are actually thinking about these nuances and not just trying to figure out what kind of sensitivity training can we have to like gloss over what community folks need. So a lot of what I've been curious about and sitting with is how the larger social movements around Black Lives Matter, the increased visibility and of trans women of color, and also like the level of backlash and tension that trans masculine folk, in particular trans masculine folk of color, are experiencing, as like we are seeing nationally this real fight and contention around gender and what does gender mean. And as somebody who's worked in HIV for 13 plus years, it's been pretty disturbing, the lack of relationship between HIV as a field and these broader movements around gender and racial justice that are so connected to this work. When we think about HIV and risk for HIV, this field really needs to be able to have an approach to this intersectional, because what we know is that there are particular social factors that put you more at risk, right? And part of what I have often talked about is like, how do we even interrogate what that means, being at risk, right? So an individual is not at risk, right? But we have these structural and systemic forces in our world and in our society that actually differentially impact people's risk versus others. And, you know, I came into HIV work because of its radical roots. I came into this field because I was like, whoa, people are talking about and really embracing the way that these larger structural systems of oppression are affecting people's lives and like actually leading to people's death, right? And that that's preventable and that we can do something about that. And that the radical advocacy that kind of birthed this movement that, you know, I was excited to be a part of. And it's been really, really, really sad to see just the lack of conversation in mainstream HIV around like anti-blackness, around transphobia. Before we even get to transphobia, just like what is gender and what is masculinity. Um, and so it's been really, really important to me to, in particular, prioritize the needs of trans masculine people of color. I think that when you start to look at multiple levels of marginalization, we are just not there yet in terms of prioritizing folks' needs. And what we know is that when you prioritize those of us who are most marginalized, we all benefit, right? And what that looks like in terms of our care for people, a lot of times I'm really sharing out with providers and organizations like there are trans masculine folks in this work and trans masculine folks of color in this work that aren't supported, who have to deal with barriers, whether it's around education, whether it's around even working in organizations because of a certain level of hostility, right? And so there are very practical things that we can do to support people from these communities being able to thrive in these fields and not have just one of us, right? So I'm sure that we've all been at tables where we're like, we're having to represent our whole community, and actually we need to move away from that, because a lot of what we're going to be talking about today is just like the huge spectrum of experience and diversity, and what do these words even mean, right? So what does it mean to be transmasculine? What does it mean to be gender nonconforming? How are we thinking about those things as a field and as a movement, but how are we actually creating the space so that people get to define that for themselves and they don't have to fit into these check boxes that get handed to us by, you know, organizations like CDC, which, like, no shade, right? But like oftentimes we're trying to figure out how to help community in these very confined ways that aren't actually liberatory. And you know, for me, this larger conversation around trans MSM to me is really connected to healing and what does that healing work look like. So, you know, I appreciate that we're already talking about like what are the other things going on in people's lives that impact their ability to negotiate sexual health, right, and pleasure and desire, right? So what does mental health have to do with this conversation? What does poverty have to do with this conversation? What does violence have to do with this conversation? And I think more and more we're seeing that as the even the mainstream consciousness is shifting around race and gender and our understandings of these things, what that means for people in community is having to navigate more hostile terrain, right? So as we are being forced to look at ourselves as a culture and how we've really failed people, people are acting out, people are showing out. And I know that in the spaces that I work in terms of HIV, even as a provider, I've noticed, oh wow, people are feeling a little bit more angry and anxious and feeling like they can just say things now. They have permission to say things that are actually really jacked up because there's this, it's like a pot that's about to bubble over. And so for me, this conversation is really important because what is our responsibility as providers and as a field to actually talk about intersectionality, not as a buzzword, but as looking at the ways that systems of oppression collaborate to keep a lot of us out of care. This other piece about research is so interesting. So I am a total science nerd, right? And like came into myself, you know, as a young person, as a scientist. And I think that, you know, I'm always very cautious. I have a lot of caution around research because often communities of color are either ignored or were experimented on, but then the benefits of that research never reach us. And so how are we actually pushing people to make sure that those things no longer happen?
Thank you, Erica, for many things, including bringing it today and really telling the truth and being that truth teller. Just everything from what's going on nationally and how that trickles down. You know, it's so hard to talk about this in this short amount of time, but thank you for providing that overall picture of everything that is so hard and so much healing that there is potential for. Let us now hear from the wonderful Dana to tell us about the work that's been going on at Fenway and other places around transmasculinity, sexual health, and HIV prevention. Dana, take it away.
Great, thank you, Yamini. And thank you, Erica and Brandon, for setting the stage just so perfectly for me. You couldn't have done it better. Just because I think, based on what both of you were saying around just the intersectionality and just the interplay between gender identity and sexuality, it's such a complicated thing to try and capture as a researcher, and I hope people can appreciate that. Especially Erica, as you were mentioning, the check boxes. How do you even capture gender identity? Because when you put that on a survey, people are like, I don't like any of these selections. So now our surveys are like one page to capture gender identity and allowing people to capture, express that in their own ways. So, just because of that, because it is so difficult to capture a lot of this data, there is just this dearth in research, especially around trans MSM sexuality and sexual health. We have very few studies that do exist that capture the data, and even the ones that do exist, it's small sample size, or it's just kind of been lumped in with another study. The analysis may not be the best, and they're not really looking at a lot of the intersectionality that Eric is talking about. And then oftentimes, just even in the conception of research, trans MSM are not included, just because it's so hard, I think, for researchers to conceptualize, and also just this conflation of gender identity and sexuality, and how do we accurately and adequately divide those two things and capture that information. And then also, I think, sometimes people's just inherent beliefs around trans masculinity, and if you're going to go through this process of transition, obviously it's because it has to do with your sexuality and that you sleep with women, and and that's the masculine role that you want to partake in society. So I think even some of these microaggressions in research and in the conception of research exist and are contributing to this lack of research. And so it's really kind of just been baby steps, and we're just really starting to collect data around trans MSM and the experience. Part of it was even just laying the stage of being able to show that trans masculinity is not the same as sexual orientation, and that you can't predict really any type of behavior orientation based on those. Even in 2011, when the National Center for Transgender Equality and the National Gay and Lesbian Task Force, they did the National Trans Discrimination Survey, and we did an analysis where we pulled out a little over 2,500 transmasculine respondents. 82% identified as something other than heterosexual, with 51% being queer, 19% gay, 12% bisexual. So this really sets the stage. Unfortunately, NDTS did not collect actual sexual behaviors that were happening, but you can kind of hypothesize that if the identity is that varied, then the actual behavior is going to be very varied as well, and potentially engaging in activities that could put people at higher risk for HIV. And the studies that do exist thus far, the prevalence of HIV among transmasculine individuals, it varies so widely just based on the study, ranging from 0% all the way up to 10%, which I think is a little bit of an outlier, but hovering usually around 1 to 2% in these different studies, keeping in mind that these are very small sample sizes. But even though that 0 to 2%, and 2% sounds like a small number, you have to remember that 2% is still double the general population. And so thinking about this and then actually doing work to address these this really inequality in this HIV prevalence. And up until recently, there had been no interventions that really actually spoke to the trans experience. Really, the first one was Project Life Skills coming out of Chicago. That right now it's in a 5-year efficacy trial, and we're actually just wrapping that up. It's going between here and Chicago, so Boston and Chicago, and really kind of actually this is with trans women, and so this is a lot of where the actual work comes from, is starting with trans women, and that's where a lot of the HIV research just in trans populations in general comes from. But now actually moving into, as part of Project Life Skills, we actually did a little sub-study, which is actually the first study that I came in to do here at Fenway, adapting the life skills intervention, which it's a group-based intervention for trans MSM. And so part of that was even just doing the foundational work of focus groups and sitting down with folks and saying, okay, what is contributing, you know, what are kind of some of the things that are happening in the community that may, you know, contribute to risk, and doing so, and it's a fine balance, and doing so in a very sex-positive way as well, of being able to talk with folks and be like, we want people, as Brandyn was saying, to be able to go out and have, you know, hot sex in whatever way you want possible, be safe. And so, you know, really talking with folks and understanding what is the reason of why people are engaging in potentially high-risk activities. And, you know, hearing things just from, it varies at different levels too, from like global systemic like problems of there aren't barriers that necessarily fit transmasculine bodies. You know, I remember one person saying like, I'm too small for a condom but too big for a dental dam, you know. That's something. And then also interpersonal issues there of, you know, interactions with the gay male spaces and not necessarily understanding, you're not socialized in that space. And then also, you know, transphobia in gay male spaces, and lots of misunderstandings there. And then down to the intrapersonal as well, and just people's own conception and potentially using high-risk sexual activity as a means of gender affirmation. Which, you know, if you identify as a gay trans MSM, that is a means of affirmation. So it's just very, you know, setting the stage of like understanding these different layers that contribute to the HIV risk is really important, and really important to address when we're creating these interventions and doing any type of preventive work. And then also, as Erica was saying, really taking into account some of these other syndemic factors that are prevalent in the community around, you know, homelessness, around substance use and addiction, and building those into the intervention. And talking about how those two intersect, because you can talk as much as you want around safe sex and HIV, but if you're not talking about all of these things that contribute to the HIV research, then it's kind of null at that point. You know, you're missing a giant chunk of what actually needs to be talked about. And then also remembering to keep these interventions developmentally appropriate. What works for very young, you know, trans MSM may not be the same for older trans MSM, and older trans MSM still have sex. Like, people still have sex as they get older. So making sure that these things are developmentally appropriate as well. You know, so as we kind of move forward, and, you know, what Yamini was saying in the beginning around like these gaps in research, you know, there I think are more gaps than there are, you know, filled in spaces, and really starting to look at building in like trans MSM in the initiate of when you're actually like envisioning these studies. You know, even some of the larger, like, I wish IPREX would have thought about this back in, you know, back in the early 2000s when they were doing the initial PrEP efficacy of how can we build our studies to include trans MSM and be sensitive to the actual behaviors and conduct of trans MSM as well. But then also conducting studies very specifically with the transmasculine community, you know, which we're trying to do some here at Boston. In Boston, obviously it's hard because you have to have the numbers to be able to do it. But we need to be exploring lots of different things, not only around interventions, you know, but also around biomedical interventions as well, you know, PrEPs, just a lot of the different things that are happening. Trans men really need to stop being excluded from this research. And so, you know, kind of as we set the stage, I also do want to mention what Erica was saying at the end as well, is that the outcomes of our research need to go back to the community. And that's something that I know, like, myself and my supervisors here are very adamant about, is oftentimes within research, it's like you do the study, you publish the paper, and you wash your hands and you're done. And that's great if you're in the field of research, but if you're in the community, like, why on earth did I just participate in this study if nothing comes back to me and benefits me? So keeping in mind this kind of two-stage when we do dissemination of our research, of what can I give to the scientific community and what can I give to the community with which, you know, they've contributed their voices, they've contributed their time to be able to allow us to do that. And so making sure that we adequately give back to both sides of the equation here.
Dana, that was awesome. Thank you for encapsulating the work that you all have done and others in 6 minutes. Impossible, yeah, you just did it. This was great. And thank you for really bringing it back, that the outcomes of research really belong with the community. And I'm sure we could have an entire hangout on how different folks do this in different places and what are the best practices around doing that. So maybe we'll be doing that next. I just want to remind folks that are listening in before we head into Simon's presentation to ask questions in the Q&A box on your bottom right corner, and also engage with us if you have thoughts, if you have reflections about what you're hearing. Chat with us in that in the Q&A box on the bottom. And also, if you are into Twitter, use the hashtag TransMSM and the hashtag Please Prep Me to continue this conversation online. With that, I'd like to pass it on to Simon Adriane Ellis to tell us about caring for transmasculine folks in the clinical setting, what that is, what that needs to be like, what that is like, and what cultural competency maybe means in the work that you do. So thank you, and take it away.
Okay, so I'm really excited to be here, and I'm just like super sad about my 6 minutes now that I've heard everybody else talk, and I just would love to talk forever with the 3 of you, 4 of you. But I'm going to move forward, and I'm going to kind of try to rein myself in and whittle myself down to really kind of detailed clinical stuff. And I think, you know, as Brandyn said, patients have a reasonable expectation of competence and compassion and responsiveness when they're going to seek out health care. And providers are really up against a lack of training, a lack of research to inform our work, as Dana just discussed. And we're part of systems that are known to actively perpetuate oppression, and so we're a part of that. So there's all these moving pieces that we're dealing with when someone's coming into our room for care. So I want to recognize that, and then I want to just kind of talk some details. So I'm going to lay out kind of key points of tension in the clinical environment and some strategies for dealing with them. And this is informed by my work launching a successful LGBTQ health program, which largely focused on trans health and gender-affirming care for a community clinic system that served counties near Seattle geographically, but very separate from Seattle in terms of access to resources. So that program launched 3 years ago and went from 0 out trans patients at our clinic at start to like 325 or more at 3 years. So it's clearly a needed service. I've also conducted original research on trans and gender variant pregnancy, and so a lot of my thoughts about points of tension come directly from my research. And a number of the participants in that research were trans MSM. So key points of tension in the clinical environment. The first point of tension really happens before your patient ever meets you or has a chance to get in a room with you, and that's when they call to schedule their visit. So there's a lot of like voice dysphoria, especially for trans folks, so calling and making that appointment can be intimidating. And then when staff members aren't trained, there's a lot of confusion that happens. Like if someone named Kevin calls in and says, I need a prenatal visit, right? If a staff member's not trained that that's a thing that happens, then you have this whole thing that happens at the beginning and delays access to care or turns the patient away. So training frontline staff so that they have the resources they need, they feel comfortable, and they're able to provide really great service is super important. So the second point of tension that I like to talk about is, again, still before the patient meets you, and this is when they're like sitting in the waiting room and being called back. And this is a really big thing. Like we need to be sure as providers and our larger clinic systems, we need to be asking and documenting every patient's preferred name and pronouns. We need to put that in the chart in a place that everybody knows where to find it, and it's as big and visible as possible. And every single member of the team has to commit to checking that before every single patient interaction. So if we go back and we call someone by the wrong name, we not only disrespect them and cause them distress, but we also make them at higher risk of harassment or violence by fellow patients in the clinic. So it's a safety issue as well. When we're thinking about planning our care, and especially when we're talking about sexual and reproductive health, it's really important that we know what the patient is there for, so like their actual chief complaint, which is not always told to the phone scheduler because it's scary. We need to know the anatomy and we need to know the behavior. So one thing that I focus on is having like an anatomical, like an organ inventory, so that we know what body systems are present and need to be assessed, and what preventive care is needed. So if a patient has not disclosed a surgery history, I sometimes just say, hey, do you have any history of gender affirming surgery? And then many trans men will say, oh yeah, actually I had top surgery and I had a total hysterectomy. So now you know there's limited breast tissue and there's no cervix that needs your attention. And we really need to build rapport with patients in order to first even talk about sex, right? And then especially to do exams. So you need to meet your patients dressed. I do not believe in meeting patients when they're undressed, especially if you're going to be talking about sexual health and especially if they're trans MSM. So patients should be dressed and as comfortably seated as possible. And as much as possible, we should mirror the language that's used by our patients. And when we can't, we need to explain why. So we need to say, I actually need to use some very specific clinical terminology right now because it's important for this assessment to make sure you're healthy and safe. We need to really steward our referrals carefully so that if we're sending someone to another provider, we need to ask permission first. Ask before you out. Do they want that provider to know they're trans? And if they do, then make sure to provide the preferred name, the preferred pronoun. And if they're on hormone therapy, just go ahead and say whether or not you think the issue you're referring them for is related to their hormone therapy, because it's a favorite scapegoat. So if it's not on the table, is not an issue, they may just get pushed back to you. And there's so much about culture in the words that we use to talk about gender identity and our bodies. And so it's really important to follow the cues of your patients. Using first name only is a common trick if you don't know someone's pronouns, but that may not be appropriate in all cultural contexts, so you need to be aware of that and be thinking of culturally relevant ways to address your patients. And I'm going over by 10 seconds to give my little pep talk that I always say, which is, don't be intimidated, because you already have a lot of the skills that you need. You just need to apply them to the situation. So as healthcare providers, you have compassion, you have a detailed knowledge of human physiology, you have a detailed knowledge of sexual health, and you have the ability to provide patient-centered care. So just like take a deep breath and do the best you can. And when you mess up, just own it and move on. You can do it. All right, that's my thing.
That is the greatest pep talk ever. Simon, thank you. Thank you for talking about the fact that there's sometimes a lack of training, how important it is to train frontline staff. And I just want to shout out Shannon Weber for a second, who I think she coined this term, but wrote an article in which she said, every door is an open door when referring to PrEP for youth, and that we make sure that in a clinic environment every door is an open door, and that every person that interacts with patients is mindful and is thoughtful about the way that they interact. And then thank you for reminding us that clinicians do know a lot. There's no need to be intimidated. There's just a need to be thoughtful and mindful in the way that we interact with people. Awesome. So what I'd love to do now is something that Simon alluded to, actually. I think we have a pretty amazing panel here, and we just heard everyone speak and tell us their piece. What I'd really love to do is open up the floor for you all to have some reactions, reflections, questions for each other. So we may elevate this conversation and go deeper. Maybe we will just open it up. Let me know if you'd like to give us a reflection or ask a question, and I'll switch over to your screen. Is there anyone who would like to start? Anybody?
I can. So I was wondering about a thing with Dana. I'm going to put you on the spot a little, Dana, because I'm not sure that there really are data to to support this, or to really be able to flesh it out yet. I don't know that the data wouldn't support it if there were data. But one of the things that I've seen when you were talking about the 0 to 2% prevalence rate sort of estimate for transmasculine folks, I'm getting an echo.
We hear you, but if you keep going, it'll probably go away in a second.
All right. So one of the things that I have always wondered about is that what I've seen in the research shows that trans MSM as a population are engaging in significantly higher risk sexual behaviors and behaviors that are in cisgender male populations and also in trans women populations associated with higher prevalence of HIV, but we're not seeing that bear out for transmasculine people. But what we do see bear out for transmasculine people is a slightly elevated suicide rate. And so what I have always wondered about is as our efforts in transmasculine communities to reduce the rate of behaviors that lead to suicide, or reduce the circumstances that lead to suicide, the sense of isolation, the lack of relationships, the alienation that comes in misogynistic and transphobic, particularly gay cisgender male spaces. What's that going to do to our HIV rates? Because I would expect that they would go up if we don't have interventions like PrEP that are being tailored to trans MSM. And if our HIV rates stay down, then our suicide rates will stay up. How do we fix both of those at the same time?
You know, that's kind of an interesting question. And obviously, this is probably going to be the blanket statement, is we don't have good data supporting this. But even in some of the preliminary data that we looked at, you know, you have to conceptualize this with like the factor of both potentially internalized transphobia, or at least systematic transphobia, but also potentially internalized homophobia, and how that's intersecting with mental health and that mental health outcome that you're talking about, and then contributing to risk. So even with the Life Skills for Men study that we did here with that adaptation of the Life Skills Project, which was for young, so this was specifically young trans MSM, so ages 18 to 29. Actually, even just by having the conversation, we saw like increase in what's called like the transgender integration, so like better levels of social support. And then we started seeing in the trend of the direction of less sexual risk, that as we saw greater social support, like the sexual risk started to decrease. And then, you know, we didn't necessarily collect comprehensive mental health outcomes during that, because it was only a 4-month like small pilot study. But you know, I think even just making the space for the conversation has both the benefit in terms of the mental health, and then seeing really kind of where that contributes in terms of sexual risk taking as well. Does that kind of answer your question or address what you're thinking? Okay.
Thank you. Anyone else have questions or reflections for co-panelists? Tell us, Erica.
So what I really appreciate about the ARC and just even the order in which we all contributed is just like the macro, and then how it kind of gets down to like the interactions with patients. And Simon, I really appreciated everything that you brought. And I think one of the things that I'm sitting with is, so sometimes it's about information and knowledge, right, in terms of working with trans folks, and like just the huge reorientation that we're asking people to do around like just these things that we are taught to take for granted, and assumptions that we make about who people are, how they want to be referred to. But then there's this other piece that I've been seeing for a long time around just people who don't want to do that work. And so for me, I guess I'm curious people's thoughts around like education can only take people so far. But like if people aren't willing to do the internal work of looking at their own transphobia, their own homophobia, their own racism, like I feel like that's the place that I struggle with, because I feel like sometimes we're working in organizations where people give lip service to things, but they're not actually willing to do it, and they're really harming people, and then there are no structures set up to hold them accountable, because unless they're specifically working only with like trans folks, people are like, oh, well, they're such a small population, right? Or all of the excuses people give for continuing to mess up when like it's actually super harmful, and it's cutting people off from much needed resources.
Anyone want to respond or have reactions? Or anyone have other reflections, questions? All right. We're going to start taking questions from the... Simon.
It's okay. We can go ahead.
No, please respond to us.
So I just wanted to agree that like that piece of accountability is so difficult, because like when we're looking at it on every level, on the macro to the micro, we don't have any good systems to deal with accountability. Even, we think we have good systems for the one-on-one kind of very micro level, like provider to patient level, but we don't. Like you have to do something incredibly egregious to be held responsible by the systems that are built into medicine, right? Like treating people poorly and disrespecting them is not going to earn you severe repercussions, right? And just deciding not to learn is not going to earn you severe repercussions. So it's hard, because I think, and I'm addressing micro more than I love to today, but I think that's okay for the moment. I think as providers, there's not a lot of resources, there's not a lot of incentives, negative or positive, right? And we're sort of up against the time clock too. We have 10 minutes, and people are fighting that when they're thinking about growth and change, but that's also not an excuse.
So I actually, thank you for that. I want to piggyback what you just said with a question that came in, actually from Anna Forbes. Thank you for asking questions. And Anna asks, where do most frontline healthcare providers for trans men come from? So what, and she goes on to qualify, and asking in terms of basics like trans men needing vaginal pap smears or PrEP not being, or taking longer to be effective in female-bodied individuals. So where, I think in some ways the question is also where do providers access this information? How do they become competent in this knowledge to then be competent providers for trans men? Simon, will you answer that question?
I think the really unfortunate answer is that it's all very hard-won knowledge, and that you have to put a lot of work into it independently, because the information, I agree with Dana that like a lot of our answer is we don't have good data on that. So that's frustrating. But then also if you're wanting to find out what little data there is, it's not built into our nursing education. It's not built into medical education. It's not built into education for healthcare workers. So the answer is you really have to fight for that information and find it in little nooks and crannies. And it needs to become much more widely available. I mean, there is some good stuff, but you have to know where to look or ask and work hard for it. I'd love to hear what other people think about that too.
Anyone else have thoughts on that? And I just realized if you want to respond, if you could just raise your hand, because if your mic is muted, then I can't hear you. Brandyn?
Oh, there we go. So I think one of the key points there, like Simon already highlighted earlier, as providers, you already have like the basic anatomical information that you need. There is a little bit of like, how does testosterone impact this body part, or like what are the long-term repercussions or whatever, but that's stuff that you can Google. We have databases for that. That's the easy part, relatively speaking, because there's a lack of data. But I think that some of the most difficult part that I bump up against the most when I'm training providers is frankly just a lack of humility. Just being able to recognize that, yes, you have busted your butt to get through med school, and you've gone through all these hoops, and you've paid all of this money, and you think that you've worked so hard that you deserve all of this respect and all of this, like, being put up on a pedestal and whatever else it is that you might have going on in your head. And the person who is sitting in your chair in your office is the expert in their own lives. You are not. There is nothing you can learn in a school that will teach you how to be an expert in that person's life, or that person's body, or that person's sexuality, or that person's identity. So I think sometimes doing the work is counterintuitively like undoing the work, and more like undoing the things that we've been taught to believe that we have a claim over someone else's life, or a claim to tell people how they should live or how they should behave, instead of just listening to what is it that they want and how can we provide them with the resources that they're asking for to feel healthy and complete and more sure of themselves and more confident moving through the world.
Thank you, Brandyn. Brandyn, I'm going to ask you a question that came via email, and I think this question is best answered by you, and then maybe others can chime in as well. How does an HIV/STI testing organization best locate trans MSM at risk for HIV? Any suggestions on testing in larger city versus metropolitan areas versus rural suburban areas? Any thoughts on that? Go ahead, Brandyn.
So I've always found the idea of hard to reach populations really intriguing, because the question in my mind, and the question that has been discussed for me with a lot of my people, is that who is having trouble locating us? Because we clearly did not have any difficulty locating one another to organize this today. We don't have difficulty reaching one another when we're doing recruiting. When I was working for a vaccine trials unit and doing outreach recruiting, I had no problem showing up to Trans Pride and coming home with so many names and phone numbers for contacts for that research study that I literally did not have time to talk to everybody who wanted to talk to me about possibly enrolling in this HIV research study. And the cisgender recruiter that I was out with came back from that exact same event and said, I got 2 numbers and I'm not sure that they're really that interested. And so, yes, if you have white cisgender researchers who are going out to do all of the recruiting, or they're designing all of the materials, or they are, setting up all of the forms and the systems and everything that's going on in your clinic, yet we're not going to show up to it, and you're not going to be able to locate us because we don't feel safe. And anytime we try to articulate why we don't feel safe or how we don't feel safe, then there's just this pushback of, well, but that wasn't my intent, and you shouldn't be so hard on me, and I don't understand why you people are so angry all the time, and why don't you just try to cooperate with us? We're just trying to help you. And we really just don't have time to be dealing with that on top of whatever our medical needs actually are that already aren't being met. Never mind our social needs that aren't being met, and our housing discrimination that's not being met, and all of those things. So if you want to locate us, I would encourage you to hire us.
Beautifully put. Thank you. Erica, you're out in Oakland. I want to hear if you have any thoughts on this question also.
Yes, first of all, mic drop. Thank you for that, Brandyn. I feel like one of the questions that I'm sitting with right now is like, what do transmasculine folks want to know about our own community? So although I appreciate, now I appreciate what like the broader movement is trying to understand about us and put us under a microscope, but like, it would actually be really dope to have transmasculine folks have the resources to design some participatory action research that is like asking the questions that, you know, researchers aren't going to think to ask because they don't have the lived experience, right? What does it actually look like to have research come from community, come from the ground, be grassroots, and then trickle up? You know what I mean? That piece around hiring us is so important, and I feel like we have a lot of providers and researchers and leaders in this field who are gatekeepers and who are hoarding power and who just want to accumulate privilege. And I feel like because the consciousness around race and gender is shifting so rapidly, like, I feel like there's like a huge movement of like young, like really dope, fresh, transmasculine folks, people of color who are like tired of it. And there's, to me, this larger question around movement building and how are we integrating movement building into this conversation, because at a certain point, if, you know, the medical field and research, if they're not going to meet our needs, then we're going to just stop going to those places to get our needs met. And what we know about community is like we figure out a way to take care of each other. We have always done that. And so my fear is that if like HIV as a field more broadly doesn't get it together, like we're just going to go and do our own thing. We're going to go figure it out, and we're going to have to return to some of the like really radical outside of the box ways that we just did things for each other that were not scientifically proven, that probably violated all kinds of rules and regulations, but like we're tired of our community dying, and that's what it's going to take.
Mic drop number 2. Or number 10, 20, I don't know. Thank you. I would like to turn over to Dana for a second to address another question that came in via email, and I will just read it through and let you respond. Is HIV really an issue with trans MSM? The data says that it's not an issue, 0% seropositivity. Could there be issues with this data? If so, what are they? And is there a chance that trans MSM who have tested positive in the past continue to be classified as heterosexual females due to provider bias or other issues? And I think, Dana, if you don't feel like this is appropriate, then feel free to pass. But
no, I can definitely speak to it, and then I might pass as well. Is HIV really an issue with TMSM? Yes. It definitely is. And part of that, I mean, with the 0 seropositivity rates, I mean, again, these are flaws with these studies because we haven't had the capacity yet to do an actual like good study. So you know, that's really the first bottom line, is we have to actually do a profile of the community and a national sample, and not just like little pockets here and there, and most coming from rural areas. So that's really the first step. Could there be an issue with the data? There are issues with the data because they're not, you know, it's such small sample size. They're either not capturing any type of actual sexual behavior risk and like partner level risk. You know, that's one issue among many. Also, you know, self-report versus like any type of confirmation, laboratory confirmation or some sort of like, you know, getting medical records. That's another thing. And then classified as heterosexual females, yes, definitely, because up until recently, like, you know, now finally federally qualified health centers are being required to collect sexual orientation and gender identity. So most likely, like, a lot of people are going to be characterized as heterosexual females, or at least female in a patient record, because they didn't have the ability to specify otherwise. So like people, you know, even in the rough estimates of like the population, it's probably vastly underestimated because we didn't have the capacity for which to show this data. So now, you know, we may see something different being able to actually collect this data. You know, finally we're going to be counted as just as people and as individuals, and our identities are finally going to be counted. And so we may actually see very drastic changes in this data just because it may not be just a convenient sample anymore. We could actually do like chart reviews and actually do some of the studies that really need to be done. And then I think the final question risk population definitions, yes. I know even here in Massachusetts, like with some of our studies, because we do report, we work with the Department of Public Health, we actually had to do years of back work to be able to actually get them to put transgender on our HIV testing forms to be actually have that counted. So before that, it's either you had male or female, and then that is in no way an accurate profile of the risk. So there are just huge flaws with this data. But that's to say, like, there are some incredible minds working on this right now, and there are some awesome collaborations going on both nationally and internationally to actually be able to address this issue that is with this data so far, and actually get a good, accurate depiction of the community and actual assessment of the HIV risk within the community. But yes, even from what we see with these smaller studies, HIV is an issue.
Thank you, thank you, thank you. We are out of time, but this has been so amazing, and I'm so honored to be part of this today. I want to give you all a quick second each to just give us some closing thoughts. Maybe address what's next for you in this work. What do you feel like is next in this work? I would just really like to hear from you all before we close. I feel like it would be, it would really bring the conversation full circle for us. So, Brandyn, let's start with you.
Okay. I think at the core of all of this, there's obviously plenty of work to be done. And there is, I think, frankly, the vast majority of it lands in the hands of cisgender healthcare professionals and cisgender people working in the world of public health policy and any policy. But recognizing that I don't always have control over cis folks, I just want to really encourage my people, my community, all of you, that we are still fighting in this together, and we still have people that we can reach out to, and there are ways for us to go outside the box. And it may be, like Erica was saying, it may be that it's a lot harder fight, and that we're waking up every day wondering if we're actually going to live through the day. And for some of us, we won't. And I think just recognizing that we are in this together, and that we need to stand together and call for all of this together and support one another is really at the core of how we're going to get past all of this.
Thank you, Brandyn. To say the least, it's been an honor working with you on this. Erica, have any thoughts about what's next?
Absolutely. I think my commitment in this work and in this field has been to support and resource trans folks of color, gender nonconforming folks of color, as somebody who overcame a lot of barriers even trying to work in the field of HIV. It really meant a lot when there were other people who saw me and who were like, "You're brilliant," and like, "How can I support you?" And yes, there are all these barriers, and you can do it. And so I think that piece that you lifted up, Brandyn, around we're in it together, like, what does it actually mean to be in it together? And we have a lot of work to do in our own community. And we have a lot of resources in our community, right? Like, for all the resources we don't have, we have each other, and we have really, really brilliant people who are leading the way, and we have a lot of emerging leaders that we need to be resourcing.
Thank you. There definitely is so many people that are not present on this Hangout today that have put in decades worth of work. And so shout out to all those folks as well. Simon, any thoughts?
Yes, I'm unmuted. So I think similarly to the points Erica and Brandyn have been making about, like, hire us, right? I remember when I was going into nursing school, I had this experience where I went to go get just a health checkup, and the practitioner I saw, like, refused to take a sexual health history on me because I think she either assumed I didn't have sex or she was scared. And I remember thinking, oh man, how am I going to find people in this field that can help me and nurture me and mentor me, right? Like, this is really not good. So I have a commitment to nurturing the growth of trans folks who want to go into the field of medicine, want to be medical providers. I precept students, and I get more and more selective about who I will precept because I really want to be centering people who are underrepresented within medicine. So that's kind of where I'm headed.
Awesome. That is some serious work. Dana.
Oh, so many thoughts. I actually swore I'd never go into research because I had this misconception that you're just kind of behind a desk wearing glasses, and now I'm a researcher wearing glasses. But, you know, in my time here at Fenway and then also working previously in Nevada, coming to actually conceptualize research as a very, very strong form of advocacy and like very ardently believing in that, but research very patient-centered and patient-involved and patient-focused research, and really being able to move forward with that agenda and making sure, as Erica was saying, that it is responsive to actually what the community needs, and having conversations many times with, you know, sometimes some of my bosses and PIs were like, well, let's research this, and I'm like, why? You know, that's nothing I've ever heard come out of the community. So, you know, as a trans person, as a trans guy, doing research and working, you know, really within my own community, being able to bridge that gap sometimes between, you know, this kind of ethereal, like, here are the PIs and here's the community, and being able to like humanize research once again, but also make sure that the, you know, the researchers focus on the humanity of the individual as well, and really continuing to push that forward, and then also bringing that research back both to the community, and then how do we take that and really go and educate providers. I did want to put a small plug in, which I feel like horrible doing, but actually here at Fenway we have the LGBT Health Education Center, and I know the one person who was asking about some resources, you know, about educating themselves. There's some actually really good webinars and like different videos and different things on that website. One even about like cervical cancer screening with trans men. So unfortunately, yes, you still have to educate yourself, but as everybody was saying, materials are out there, so go find them.
Awesome. I know we went over, y'all, but it was beyond worth it. And there's a couple things I want to say. There were some questions that didn't get answered. I will attempt to get those answers from our wonderful panelists and respond to the folks whose questions were not answered. If you'd like to continue this conversation way past this Hangout, please do so via Twitter using the hashtag TransMSM. And also in advocating for pre-exposure prophylaxis for trans folk, use the hashtag #PleasePrepMe. There is a link to a feedback form in the question and answer section. Please give us some feedback on how we can improve, how we can do this better next time. I'd like to thank everyone watching, and this was Hangouts with HIVE. Thank you.